to the Anesthesia training series. I'm Dr. Charlotte Marquis. I'm a board-certified veterinary anesthesiologist, and today I will be talking to you about anesthesia for cats. So, definitely less popular than dogs, at least in the US at this particular point in time, but cats remain a very popular pet with our clients and our staff in general. Way smarter than dogs, a little bit smaller than most dogs, so that makes them a little more portable and, sometimes just for cat people. But certainly we see plenty of cat patients in the clinic, both for elective and emergent procedures. And just like with brachycephalic dogs, there are a couple of things which make cats have very unique needs that you do need to be aware of when you're planning both general anesthesia and sedation. So the first thing I think about when I think about cat patients are the different signalments and types of cats I see in practice. And this is just because I do treat different breeds of cat differently. They have different behaviors, different anatomic variations, things that can make them difficult or easier to work with. So I just kind of want to go through some of those things that might be and kind of how you might approach that clinically. So many different types that we have. So we have some basic breeds like DSH, domestic short hair, by far the most common, yeah. Domestic long hair, DLH. In the UK, we call a domestic semi-long hair a DSLH, kind of a regional term there. And then you have other breeds of cats which look kind of different from one another, right? So a Sphynx, this is going to be a hairless cat. Persians and Himalayans, so these are your flat-faced brachycephalic cats. Maine Coons, so these guys are really large. They can be heavier than a lot of small dogs, so that is what that is. Munchkins and Manx cats, so Manx cats usually don't have much of a tail, and then Munchkins are your tiny little chondrodystrophic cats, so think of them like the dachshund version of a cat. And then exotic breeds, so Savannah cats, Bengals, things like that. Each one of these breeds has unique challenges. For example, long hairs, they just have long hair that can be difficult to clip or to see vessels easily. Sphynx cats, I feel like, usually have very fragile skin. Persians, they're brachycephalic. Munchkins, challenging vascular access. And then some of these breeds have different instances of different metabolic or cardiac diseases. So when I think about Persian cats, I think about polycystic kidney disease, so difficulty getting rid of drug metabolites maybe. And when I think about things like exotic breeds, Bengals, and like Savannah cats, I think about heart diseases like HCM. So those would all be things to be aware of if you have a particular breed of cat you're working with. So, other than breeds, what are some of the things which makes cats just different than dogs? Why are their needs just a little bit different? So, pretty much smaller everything. So, of course, you're going to have some dogs that are tiny and some cats that are really heavy. So, if, for example, a Maine Coon might be bigger than your Brussels Griffon, right? But in general, smaller vessels, smaller airway, smaller anatomic landmarks. So, this usually requires just a little bit more time to kind of get on board with. You might need to be very deliberate about your palpation of the animal, your physical exam, so that you make sure you don't miss something. It's just going to be so much easier to do if you have a patient that doesn't have a lot of tissue to work with, right? Anatomic differences, especially when it comes to epidural and spinal anesthesia, the conus medullaris ends at S1 or L7 in cats. Now, the conus medullaris is the termination of the spinal tissues in the spinal canal. So the conus is what surrounds spinal fluid. Now, when we do locoregional in that area, we can either perform an epidural, which lots of us are familiar with. The epidural is into semi-liquid fat. And a spinal technique or spinal anesthesia goes into CSF or spinal fluid. Now, in a cat, the termination of that spinal canal ends further back than it does in dogs. So let's say in cats it ends here, and in dogs it ends here. The reason why this is important is because if you are doing epidural anesthesia in a cat, you are more likely to retrieve spinal fluid. And it's okay to inject your drugs, but you just need to make some modifications. You need to cut those drugs volumes in half because the distribution of the drug is going to be different in liquid spinal fluid than it is in semi-liquid fat, right? Because one fluid has a different consistency than the other. That makes a lot of sense, right? So, conus medullaris ends more caudally in cats than it does in dogs. Laryngospasm. So this means spasm of the arytenoids or the front part of the airway. This is something that we see very commonly in cats, but we also see this in pigs and in humans that get intubated. I feel like when I do most of my cats, very frequently I see laryngospasm, but I almost never see this in dogs. And there are some things you can do to help prevent that and limit the extent to which that challenges your intubation. Poor collateral circulation. So collateral meaning kind of coming from the side. So if you have a cat where you catheterize an artery or you catheterize a vessel, if that area becomes compromised or there's phlebitis, vasculitis in that area, very important that we treat that skin appropriately, pull that catheter out, and provide appropriate supportive care, because cats are much more likely to have things like tissue death as a result of that, just because their vessels do not do this nearly as much as dogs do. Secret metabolic and cardiac disease. So I feel like cats, they are much more intelligent than dogs, and I also find they're much more secretive. So I think a lot of cats hide their disease and their illness very well. I think you can have a cat that could be outwardly seeming healthy and cooperative, but on the inside is doing quite poorly. So it is very important to do a very complete physical exam to look at blood work and medical history and medications whenever that is possible, and trying to work out if there's a disease that you need to plan your anesthesia or sedation around. Don't just assume the pet is healthy, find out for sure. Physiologic differences. So just like in our brachycephalic talk, the anatomy leads to physiology. So this is going to be very relevant to planning both your sedations and anesthesias for cats. Challenging vascular and airway access. So I think when you're first learning to intubate and place catheters, it's useful to do that on big, healthy, friendly dogs. And then you move on to small cats. So cats, they have small vessels, the skin is very thin. It can be very difficult to find or to feed the vessel into the catheter. So I would just recommend going slow and using plenty of patience. And if your animal's not cooperative, do not be afraid of sedation. Airway access. So we talked about laryngospasm. So this is kind of a clamping down of the airway as you're about to head into it. So I feel like I see this much more in cats than I do in dogs. And there are certain medications and techniques you can use to limit the extent to which that happens. Inadvertent spinal versus epidural. So we talked about the conus in cats. So you're much more likely to hit spinal fluid when doing an epidural in a cat versus a dog. So if you hit spinal fluid and fluid is coming out the hub instead of going into the hub like it does with the hanging drop test, that's okay. But you do need to think about reducing each of your drugs by half, because the distribution of the drugs and therefore their effect on the dog or cat is going to be way different. Increased chance for skin or tissue necrosis. So cats have very thin, fragile skin. They have poor collateral circulation. So be very deliberate about, your not only like your surgical landmarks if people are doing things like that, but also pulling out catheters or pulling out alligator clips from the ECG leads if they've been sitting there a long time. Just because cats do not have collateral circulation nearly as well as dogs do. Changes in their ability to cope with different organ diseases or heart diseases. So organ reserve, cardiac or metabolic reserve, that is a term that means the animal's ability to cope or adapt to a certain load or stress. So cardiac reserve, that means the heart's ability to compensate for, increases or decreases in function, and that happens usually like with drugs or with anesthesia, right? And then metabolic reserve, so that's usually the organ's ability to deal with things kind of as they come to them. So liver reserve, that means the liver's ability to deal with, metabolize, get rid of, toxins for us. Same kind of goes for the kidneys, right? They're going to get rid of metabolites and toxins. So if your organs don't function as well, it kind of stands to reason that like metabolites and things go the other way, not leaving the animal as well, right? And because of these things, you may need to alter your medications or your fluid plans. So if you have an animal that you know has liver or kidney disease, or you know it has heart disease, you might need to make some different drug choices. Maybe that's dose, maybe that's drug selection, or you need to think about altering your fluid type, rate, or therapeutic plan. So, what are my pro tips for anesthetizing and sedating cats? My first one is, do not be afraid of sedation. I think a lot of people are afraid to sedate cats just because they have some different anatomic and physiologic variations. And I also think there's an equal population of people who just resort to sedation right away. My philosophy is you give just enough for what the patient needs, and then you can always add more later if that wasn't sufficient for you. So if your patient is cooperative, my preference is always to place a catheter and administer sedation. If your animal is aggressive or uncooperative, IM sedation or oral medication is going to be your friend. You have a variety of drugs you can choose for that. You can use gabapentin and trazodone. You can use the chill protocol. This is a fantastic option for animals coming into the clinic for planned elective procedures. Alpha-2s and phenothiazines, so things like acepromazine or dexmedetomidine, injectables or gel, can be a fantastic option for managing fearful cats in the clinic. Perform a full physical exam and workup. So this not only extends to the physical exam, like your auscultation and just a general look over, but if you have blood work, x-rays, medical history available, use that and think critically about how that's going to affect your patient's sedation or general anesthesia. For things like laryngospasm and intubation, I would recommend using topical lidocaine. So I prefer the injectable liquid. I use about 0.1 to 0.2 mils of 2% lidocaine. So I give my induction drug, I wait for my cat to start falling asleep, and when they start closing their eyes or dropping their head, I'll place the lidocaine and wait another 30 seconds to 1 minute, and then I'll attempt intubation. I usually find that by doing this, not only can I get away with intubating them faster because I've waited that 30 seconds, but also I've used less propofol. So this is especially helpful in your very debilitated patients where you think they're not going to tolerate that. It's also mean it's going to be easier to see the airway because it's going to be open. Most of the time, I feel like if they're still clamped down, it's usually because they've had inadequate muscle relaxation. So you can think about giving more propofol, give a benzodiazepine, or do something like an alpha-2 agonist, and this does help a lot. Definitely try to intubate as soon as you are able, but don't worry about getting the airway secured so fast that the cat is just clamping down, because that is not good for them. I would be very deliberate about your use of a stylet. So limit your stylet use until you've had more than one unsuccessful attempted intubation. So let's say you've given your cat pre-meds, you've given induction agents, you've done your lidocaine, and the cat is still clamped down. I would recommend giving more induction drug and waiting another minute on oxygen mask before attempting again. Lots of people think that the purpose of a stylet is to help get it through the arytenoids itself, but that is actually not true. So the purpose of a stylet is to prevent the endotracheal tube from kinking as you pass it through the airway. So you know that endotracheal tube material is soft and flexible and it warms to body temperature. Especially if there's a lot of saliva in the oral cavity, what the tube can do is it just kind of slips around and it kinks or it falls back on itself. So that's what the stylet helps prevent. It helps prevent the tube from deforming. But what I will say is that because it does that, it makes the tube rigid. So if you have a cat that has a rigid closed airway and you just try to jam past that with a stylet, you are going to cause the cat damage. The other thing that the stylet can result in is something called a tracheal tear. And the danger of this is that if the trachea is torn, oxygen and anesthesia gas is not going to go into the lungs and keep the cat asleep. It means your cat's going to desaturate and it's going to blow up like a balloon. Now, thankfully, this is exceedingly rare, but I would try to limit your use of stylet until after you've given the cat sufficient time to fall asleep and get relaxed. Hopefully that makes sense. If you hit spinal fluid and you're doing an epidural, it's okay. Just cut your drug volume in half. So if you're doing an epidural with a 0.5 ml of morphine and a 0.5 ml of bupivacaine and you hit spinal fluid, oops, just reduce the volume by half, so it's going to be 0.25 and 0.25 of each. Same thing applies to dogs. Full mu agonists and NSAIDs are your friend. I think a lot of people don't forget about this in dogs, but we're very quick to forget this in cats. I think a lot of people are very wary about using things like hydro or morphine or methadone in cats because they feel like buprenorphine works just as well. I can tell you from both a pharmacologic standpoint and a clinical standpoint, I do not find that to be the case. So we know that full mu agonists, so morphine, methadone, hydrofentanyl, they are going to provide more intense, efficacious analgesia and pain relief compared to something like buprenorphine. The other downside to buprenorphine is that because it's a partial mu agonist only, but it has very high affinity for the receptor, that means that it's not going to leave the receptor and it's going to hold really tightly to it for 6 to 8 hours. So if you give buprenorphine and decide it's not enough, you're going to be hosed for 6 to 8 hours until that displaces from the receptor. So I would always think if you're getting scalpel to skin painful surgery, use a full mu agonist. The cat, if it has sufficient analgesia, is more likely to be cooperative if it feels comfortable, right? And NSAIDs too. Lots of people are afraid to use NSAIDs in cats. If you have a healthy euhydrated cat and you have blood work available and you feel like the cat is euvolemic, then it is appropriate in most scenarios to use an NSAID. You can use meloxicam. There are many studies about how meloxicam is safe for long-term use in cats. You could also use robenacoxib. So in your patients that can tolerate it, think about using multimodal analgesia that includes both an NSAID and a full mu agonist. If you are someone who's placing art lines in cats, good for you. I find that to be a very challenging skill, but useful. If you're putting art lines in cats, I would recommend pulling the art line within 24 hours. Now, it's certainly appropriate to leave that in the patient post-op if you have a very sick animal. And in dogs, I might leave it 3 to 5 days. But we talked about how cats have poor collateral circulation. What can happen is that if you catheterize the artery and we get vasculitis in that area, is that we can have tissue necrosis. So I would just be very cautious about leaving them too long and maybe think about putting a warning on the treatment sheet, a kennel, or a timer on someone's phone just so we can pull that out in a good enough amount of time. Last thing I want to say is that especially when it comes to cat management, but also when it comes to pain, pain is not just a physical thing, it's also an emotional thing. So fear, anxiety, distress are all pro-pain states in cats. And I think for that reason especially, it's very important to consider fear-free practices both in cats and in dogs too. So when you have a feline patient, I would recommend trying your best to be gentle yet firm. And if sedation isn't the only thing you have access to, think about things like cat appeasing pheromone. Handling techniques like towels and blankets can make the cat feel a lot better and make them a lot more cooperative, which is going to make your life a whole lot easier. It also extends to things like appropriate nursing care and kennel setup. So most dogs will be fine if you pop them in a kennel, but it is really important in a cat, especially if it's hospitalized, to have maybe a blanket in front of them, maybe a place that they can hide. And that makes them so much easier to get out of the kennel, to handle, and just to start working with before you do all of these other things that you're doing to keep your cat safe. And that's it.